Welcome back to Your Health, and today we are looking at the health sector and the backdrop of the Health Act 2017. And just before we went on break, we had Mr. Daniel Yumbe, who is the Chief Executive Officer of the Kenya Medical Practitioners and Dentists Board, and he had just given a few insights on the Kenya Health Professions Oversight Authority, where only 2 of the regulatory bodies are represented or are said to be represented in the Health Act. And Mayaka, you had a few burning points in reaction to what Mr. Yumbe had to say. So
it's not really a reaction, Dr. Mercy. It's not really a reaction, but I will want to pick up from where Mr. Yumbe stopped. Yesterday evening, I was going through the Health Act, and I realized that it has established 2 bodies, and that there is provision for establishment of more 2 bodies, right? When I was looking at the functions of these bodies, I'm talking about the Kenya Health Human Resource Advisory Council and the Kenya Health Professional Oversight Authority. One, I did realize that actually this act is not exact, does not meet the expectation and the intention of key stakeholders. Why do I say so? Like the Kenya Health Professional Oversight Authority have seen duplication of functions and roles which are played by the existing regulatory boards, right? Then look at the Kenya Health Human Resource Advisory. Does it have teeth? So that if it's management of human resource centrally, right? Does this authority have teeth that it can dictate and say, this is what we want, and they can engage with the health workforce, right, and come up with the tangible solutions which will actually cap and address the issues we are talking about, industrial actions and also regulations. This act has attempted to define who is a profession, right? Really, yes, from where I'm seated, a profession must have gone through
the requisite training,
exactly, the requisite training, internship,
registration on the,
and registration by the licensing bodies. In the health sector, we have got unregulated professions. So this act has not addressed their plight, right? These are people who are giving services to the health, to the Kenyans, right? And at what point can we be able to pin them since they are not in law?
Just for clarity, which are these unregulated cadres that you are talking about?
In the health sector, we have about 18 professions, right? We have 18 cadres in the health sector. It's only 9 who are regulated, who have regulatory boards. The rest don't, right? So that means when it comes to regulation of their services, job description, scope of practice, right? It's not entrenched in law, right? These are people who are working by virtue of Ministry of Health policies. So then, and we are talking of quality health care services, universally accepted to the Kenyans, right? We must have also people who are responsible, people who are accountable. And that is what I expected this act to address, which it has not addressed. Look at the administrative and managerial positions in the health sector. When going through this act, I've realized that there is a preserve of certain managerial positions and administration to a certain cadre. And that is discrimination. We're not going to allow that.
I'll actually specifically ask a question on that, because I know the other cadres have raised issues that, you know, the leaders of most of these bodies are reserved for doctors, medical doctors. But before we get to that, Dr. Njoki, is the Human Resource Advisory Council and the Professions Oversight Authority, is it a cure? Does it prescribe a solution to the issues that we've raised that are plaguing the health sector?
I think in this country we have a history of having faith in bodies in their formative kind of space, as opposed to starting to analyze them when they have been established and they're active. I think it has the potential to really go a long way. I especially think it does if it has equal participation, or at least significant participation from the unions in these conversations around regulation, so that the regulatory bodies don't have conversations that exclude the unions, and then the unions have a problem later. So if they can figure out a way in which they can either communicate, or where the unions can have permanent seats on some of these spaces, such that nobody can then say that the unions were caught blindsided, and that the unions, in their stead as the representatives of the wider healthcare bodies, will then now have to go on strike or do go slows to complain. We really want to evolve, especially in health, but in general, we want to evolve past a place where we can only solve human resource problems by industrial action. The industrial action ideally should have been taking place before. We should have been having some of these very fiery conversations in our boardrooms, in the public, in the public sphere, before it even gets to the point where people have to down their tools. I think I want to respond to some of the things that were raised by Mr. Yumbia, if I may. I think it is important to recognize that there has been progress. The progress must be seen, however, in context, and the context, and especially this year, has been the vast gaps in as far as human resource satisfaction, and the gaps that the people of Kenya have been experiencing. I think it is good that we are getting better equipped. We look forward to a day, for instance, when every single county and every single small public healthcare facility has an ultrasound, for instance, and somebody who can read ultrasound results, such that our pregnant women do not have to go all the way to a level 4 or a level 5 facility, so that they can have an ultrasound to understand what's going on in as far as having a baby. And these are the things that Beyond Zero and other such initiatives, and also our whole conversation around reducing maternal mortality, even excluding Beyond Zero, have been trying to address. So equipment is fine. This equipment needs people to run it. So if the people are not going to be happy, then there's nothing we can do. I think Mwongozo as a guide for public service has its excellent points, but the bureaucracies that Mwongozo outlines have to be able to be flexible to meet the needs of every single sector. So the things that Mr. Yumbia was saying about how Mwongozo says this, we find that this is actually what is practical. And again, what Mr. Thaddeus was saying, that we can't have some people represented and some not represented, and we even are at a point where not all the people who should be regulated are regulated, let alone so that they can't even reach the point where they can be represented on a body if there were going to be such a body. So we need to reach a place where we have all these parallel processes that meet at a point where everybody, first of all, gets regulated. Then now we see about having this body that represents us all and not some of us. And again, just like Mr. Thaddeus said, we cannot afford to continue this situation where we imagine that having a doctor at the helm means that they are speaking for all of the healthcare cadres. As a doctor, you only know what a doctor does as yourself. And then you can see what other people are doing by proxy, but you are not them. You don't know what they're going through. You haven't had conversations with them. Again, hospitals don't encourage meetings where people get to know one another and exactly what one another do. We just kind of experience these things as we go. So even as we try to speak for bigger engagements on the levels of the unions and at these macro levels, we should also encourage them at the level of the healthcare
workers
space
individually.
and the individual workers. Yes, I think I wanted to say something about the private sector and the public sector.
Before we'll specifically come to the public-private partnerships, because the Health Act has actually indicated that, and we'll be looking at in the long run, is it beneficial to the taxpayer? But before we get to that, we went to the streets, and as usual, we talked to Kenyans and get their ideas about what they think about the topic. And this week, we were asking the Kenyans in Kitui and Nyeri whether the health sector is actually working for them, if there's any improvement in the health sector. And this is what they had to say. Take a listen.
Serikali kuu na serikali za kaunti zimejaribu pakubwa sana kuona kwamba sisi kama wananchi tunapata huduma safi katika zahanati zetu na hospitali hizi kubwa kubwa.
Watu wa Nyeri hatuna madaktari. Vile tunasema daktari, gavana wetu wa Nyeri atutafutie watu wamesoma, watu wale wanaweza tibu magonjwa ile iko Nyeri.
Ukienda village dispensaries unakuta manasis na daktari wako gangari kutibu watu.
Mtu anapoenda hospitali anakuta kuna issue, pengine kuna madawa, pengine nurses hawashikilii, wamegoma. Those are the issues still about the CSS. the minister alikuwa anashughulikia sana.
Naridhika na hizo huduma sana. Unaenda huko unapata dawa, hakuna line, au madaktari wanaongea na wewe poa. Useme siku hizi.
So those are varied views. Some Kenyans thinking that, well, there's been improvement in the health sector. Some saying, well, they don't have doctors or some services are not available. Is this the case on the ground? Listening to what the few Kenyans we talked to had to say.
I think the mixed view, sorry, let me just finish.
Okay, you finish.
I think the mixed view is the truth, that there are some people who've been able to experience really good services, there are some people who've not, and then the thing that we have to do is to understand what is this gap. Why are some people consistently unable to get good services? I liked that you mentioned posting of healthcare service providers to certain areas, and certain areas are considered hardship areas, whether it's because of lack of access to the amenities of life or lack of access to the services that the public servants themselves would like. So this is a wider conversation even for other public servants who are not within healthcare. What do we do, and what do we give some of these public servants who go to serve the population in vastly underdeveloped spaces? And how is this conversation about sending public servants to undeveloped spaces, how is it affecting the general development conversation, and why aren't we having that conversation already?
Okay, Thaddeus.
Well, thank you very much. Before I react, because I will forget,
yes.
Before I react to the views of the public,
yes.
There's something I really wanted to say about this Health Act, right? As we discussed, because I may forget.
Okay.
And this is not only my personal opinion, it's also the opinion of the people we represent, right? We feel strongly that actually the operationalization, how to operate this, let the Health Act be suspended first, right? Okay. And then there are sections which need to be relooked at. Because if it is implemented and is being operationalized, there are going to be other issues, challenges which will arise, which will impact negatively on the provision of health services in this country, including training and regulations of professionals. So what we are saying here is that let this Health Act implementation be suspended first. Let all the key stakeholders be brought on board, right? We'll look at it comprehensively and address the sections where we feel there are challenges. Now, when it comes to the public, you have heard what they have said, and I do agree with them. There is actually that mixed reaction because there is no unification in the health systems in this country. And that's why before the health sector was devolved, as health professionals, we said kindly, let us not devolve health sector in totality. Let us unbundle functions one by one. Do you know why? Because we wanted to have a level playing field. You saw during the industrial actions, some county governments felt that they needed to do something about their health professionals. And they were calling them back. Others want is because there is no unity, there is no synchronization in the management of health systems in this country, and that one should be addressed.
You bring up a very important point, let me call it an important point, about suspending the implementation of the Health Act. But before a bill is passed and becomes an act, stakeholders are involved, discussions are, are held among different stakeholders that are key in this. And I know for this particular Health Act, it's been work in progress for many years, and both national and county governments were involved, and all the professionals were involved. Are you now saying that the stakeholder consultations were not adequate to have a document that will work?
Dr. Mercy, let me tell you from an informed choice. At the initial process of the Health Act, the bill, all stakeholders were involved. This bill went to Parliament twice, and you remember we called it back twice or thrice. The last one now, which was enacted into law, that is where the problem was. And I can tell you, without missing my words, there was manipulation of that bill at the last bit. That's where you see these discrepancies we are talking about.
Okay.
So therefore, I'm asking that it is not too late for all key stakeholders, right, to get back a group and look at it. Because I have word, and this one I can question you, I have word that actually there is a section of stakeholders in the health who are going to court to make sure that there is no implementation and operationalization of this document.
2017. Okay, both of you had raised issues about the public-private partnerships. And my question to you just briefly is it beneficial in the long run to the taxpayer?
Let me first quickly say something about the people going to court. I don't think legal instruments are perfect. I think the process of revising, taking them back, finding out that actually while this thing was being built, the context has changed, and so the instrument needs to shift again. What we find consistently is that the people and the society move a lot faster than the law in several ways, shapes, and forms. And so for me, it's not a bad thing that several stakeholders want to take the Health Act to court and start kind of unraveling it and saying this is what doesn't work, this is what doesn't work. I don't think it negates the stakeholder conversations that were had before. What it just does say is that we find that this sector moves a lot faster than the law can catch up with it. And I think the back and forths are incredibly important so that we can have an instrument that truly serves the needs of the people of Kenya. As far as public-private partnerships are concerned, the thing that we first have to do is locate what public goods are. And health is a public good. So we cannot say with honesty or integrity that we are providing a public good well or efficiently if conversations look like they are favoring the private sector. Because the point of the public good is that it's supposed to be as available to as many people as possible and it's not really a market good in that way, shape, or form. We don't give health or healthcare services according to who can pay most for them. We shouldn't be negotiating the comfort of the people of Kenya as a factor of who can pay the most. We shouldn't be negotiating whether people should have, for instance, linen on their beds or pillows when they're convalescing from an illness. We shouldn't be negotiating things like the availability of healthcare workers. All of us know the WHO ratios. We know the number of doctors you're supposed to have in any size of space. We know the number of healthcare providers we're supposed to have in any ward setting, in any wider public setting. So we know these things. And so the thing that we have to cycle back and accept is that because health is a public good, we can't give it over completely to market forces. And that's the thing that we've been seeing happening. That said, I think the public-private conversation can be an incredible thing. We just have to regulate it very strongly so that it can serve the interests of the people of Kenya. To just kind of wind up, I want to say that we need to figure out NHIF, but then we can't continue this either-or way of doing things where it's either NHIF or private insurers. A lot of private insurers have been coming out to say that actually they would like to work in concert with NHIF such that they can co-pay. And so when we have some of these hybrid models, the people of Kenya can be served much better.
Okay. Mayaka, just your comments on the PPPs and yes, just to wind up.
On the public-private partnership, my biggest question is in whose interest, right? So that at that level where people are coming or the governments are coming into agreements and MOUs, is it that we are going to strengthen on the health service delivery? Are we going to subsidize or are we going to right? So then, what I must say is that, again, I don't want to be misquoted, is that previously we have seen that kind of agreements at the county level and the national government, but they have turned out to be cartels, right? Who are actually stealing from the public.
Okay, so I think we have just scratched the surface on this issue of the health sector and the Health Act 2017. Well, we've seen that from my panelists today that, well, we still have a deeper conversation to have on the health sector and where we are sorry for that, where we are going in this health sector, what the Health Act 2017 in regards to the human resource aspects of it, what it entails for you, the Mwananchi. And with me today is Dr. Njoki Ngumi, who is a health caregiver, Mr. Thaddeus Mayaka, who is the chair of the Nursing Council of Kenya, I beg your pardon, and we also had Mr. Daniel Yumbe, who is the Chief Executive Officer of the Kenya Medical Practitioners and Dentists Board. And that's where we wrap up today on Your Health. I'm Dr. Mercy Korir, and I hand you back to Michelle Ngele.